My name's Edelstein. I'm one of the PAs at Edelstein emergency room. We'll go over today when to visit the ED, some differences between ED and urgent care and primary care per se. So some basic terms or abbreviations. ER is emergency room, EM is emergency medicine, ED is the emergency department. ACEP is a governing body of emergency medicine, which we all have to be enrolled in to maintain education and state privileges. You might see urgent care advertisements or ER visit wait times on the television, as well as big pharma that goes over certain medications that could be dispensed either at the emergency room or through urgent care. There are standalone emergency departments, I think mostly in Florida, but Stony Brook is opening one in East Hampton. So they do offer emergency services, and if you have to, God forbid, be admitted or have surgery, then they usually will transfer you to the standard Stony Brook or Southampton. And then UC is an abbreviation for urgent care, which there will be, the closest one would be CDMD in Cutchogue. So who am I? So I am a physician assistant. I work in the emergency room at Eli. I've been there for about 15 or 16 years. I'm part of the team that includes the doctors, the nurses, respiratory techs, patient care advocates, the lab, and we all work in concert to take care of everybody. Again, radiology as well as the lab helps us make diagnoses and treat your ailments. And other certain consultations which we can get out at Eli would be general surgery, orthopedics, infectious disease, neurology now, because we have teleneurology and telestroke, as well as any other services that we could reach via phone and telemedicine at the main Stony Brook in Stony Brook. So emergency medicine, everybody, you know, whether you come in with belly pain or a headache or leg pain, most of the time we will have a formative diagnosis for you, but sometimes we don't know what it is. But the main focus of the emergency medicine is to rule out anything that's bad, which is why then we might send you for a consultant. So if you're coming for leg pain and we can't really figure out what's going on with like an x-ray, which is normal, or we made sure you didn't have a clot in your leg, we would send you to an orthopedist. So we might give you a diagnosis of leg pain or leg strain, but that might not be the final diagnosis. We just want to make sure nothing is eminently dangerous. So again, we're to exclude any conditions that will cause a permanent or limb disability. So again, for emergency medicine, there's the EM physicians, doctors, there's the PAs, there's nurses, there's respiratory therapists that will take care of any breathing, asthma, pneumonia, give you treatments. They will also apply oxygen via masks if need be, with our orders, of course. There's patient care associates, which might transport you to x-ray or other services. The radiology technicians will come and do your x-rays and your CAT scans. Labs might come up and draw your blood, and they run the labs downstairs in our lab. And there's pharmacists in-house now 24 hours a day at Stony Brook, which will go over our orders to make sure we are giving you the appropriate medications on dosage and weight based, as well as making sure there's no interactions with any allergens and other medications. So this is a sign actually, I think it's in North Carolina. So if you stepped on a bee, is that urgent care? Or if you stepped on a beehive, is that emergency care? So whether or not you know you have anaphylaxis from a bee sting, you probably already know you should go to your emergency room. But if it's a localized one bite, you probably go to an urgent care versus stepping on a beehive where all that venom needs to be taken care of with an IV medication, which usually urgent cares don't do. So when you go to the ER, so there's a term everybody uses, it's called a prudent layperson. So basically that definition is that any emergency department has to see anybody for any ailment, no matter what it is. Just because you as a prudent layperson might not know that a sore throat means you have an abscess, or arm pain or leg pain means you might have a clot. So Prudent layperson means if you're concerned about billing or you should go to an urgent care or ER, it falls under the umbrella of prudent layperson that everybody is entitled to a medical screening exam, whether it's at the urgent care or through us. So here's some top 10 reasons to go to the ER. So severe depression with thoughts of suicide. So an urgent care would not be able to take care of that. Obviously, they would defer that to us. Whether or not they would have to call an ambulance to come and safely transport somebody to us, that's another story. But here in East Long Island, we have robust psychological services where you would be seen by psychiatry and the residents and be taken care of in a safe manner for you and or your family members if need be. So wounds that need closure. This can be seen in urgent care. They do sutures there. Whether or not it is a large enough wound where it needs a surgical intervention or the wound care center, which we do have at Eli, the urgent care can sort of assess that need and transfer it to us if need be. But urgent cares do sutures as well as us, but they won't have a connection to general surgeon and or plastics. So bleeding. So if you're coughing up blood, right? If you have bleeding from your nose, if you have bleeding from your GU tract, or if you have any rectal bleeding, especially now people are on all the different types of blood thinners, Eliquis, Xarelto, Coumadin, that's usually an ER visit where we could check your bloods to see if you're anemic or if your bleeding times are too long, where an urgent care gets blood back 24 hours after the fact. So they won't be able to really assess the severity of the bleeding in real time. So that would be a reason to come to us. So trauma. So a head injury, even in the elderly, that's still considered a reason to come and see us, especially with all the blood thinners. And as we get older, our brains shrink a little bit. So if you hit your head, there's more room for the brain to shift back and forth to hit the skull, which might increase the risk of bleeding. Chest pain, again, urgent cares can do an EKG, but they can't run any bloods to see, God forbid, if you're having a heart attack. Back pain, that's sort of a Pandora's box, but we want to make sure that there's nothing like an aneurysm, which they cannot do in the urgent care. Abdominal pain, again, they won't be able to get a CAT scan or anything from an urgent care. They probably would send to us. And any broken bones that need to be set or really splintered or seen by orthopedics, again, that would be through us. So again, the beehive versus the bee. So if you need antibiotics for a cough, you think you might have bronchitis, sure, an urgent care might be sufficient to see. But if you got stung by a multitude of bees, or if you got bitten by a snake and you need antivenom, that would be the emergency room. So fever. A lot of fevers go to the urgent care. That's mostly in the pediatric population with ear infections or strep throat. But a fever in the elderly or as we're getting older, we want to make sure there's no sepsis, which again, they cannot rule out in an urgent care, so they will send it to us for blood work and antibiotics. And fever is a function of age, meaning pediatrics with fever are way different than us as adults. So if we're mounting 104 fever, there's something severely wrong, like sepsis versus pediatrics, which could be an ear infection. And a fever is 100.4 or higher, orally. All right, anything sudden is usually not a good thing. So sudden headache, that could be an aneurysm and to ruled out, so that's emergency room. Sudden abdominal pain, that could be another aneurysm or something perf like an appendix or diverticulitis. Back pain, again, we are thinking about aneurysms or kidney stones, which we cannot rule out properly in an urgent care, so they probably would be sending you over to us. So an acute allergic reaction. So like we said, if you stepped on a bee and you know you have anaphylaxis and you don't have your EpiPen, that is an emergency room visit because you need to get Epi and be monitored. They do not usually give emergency medications in an urgent care. They do have EpiPens, but they're going to ship you to the emergency room because you need to be observed for 4 to 6 hours. especially after epinephrine.
Yeah.
Shortness of breath. It's not sort of another Pandora's box, but the main thing here is making sure you don't have pneumonia or, God forbid, something called a pulmonary embolism or a clot to your lungs. So most urgent cares can do a chest X-ray. So if it's a cough or they want to make sure you don't have pneumonia, but other than a chest X-ray, they cannot do any more real screening exams with the only having an X-ray, not having a CAT scan or ultrasound. Chest pain. Chest pain, again, like I said, it's got to be depending on your risk factors, how old you are. Urgent cares can do an EKG and a chest X-ray, but they can't do serial blood work, something called troponins, to make sure this is not an evolving heart attack or anything different. So depending on your risk factors and the way they stratify you, they probably would send you to the ER. And obviously, number one was, God forbid, you think that you're having a stroke. That is immediate transfer to an emergency room, because time is brain, and we're equipped now to sort of handle any stroke emergencies, being that we are getting accredited for stroke services. So we have, we're getting another CAT scanner. We have, as well as we have telestroke and teleneurology. So that's something that basically that's 911 immediately, so we could take care of it and get you the proper treatment. So stepped on a mouse trap, you might break a finger or a toe, versus a bear trap where that might be, God forbid, amputation. So one obviously is an urgent care, one is an emergency room. So when to go by an ambulance, which is again 911. Again, I can't stress enough, it's with anything neurologically, or God forbid you think you're having a stroke, or you're witnessing somebody that you think might be having a stroke. Is that if you need on-scene care, if you need destination triage, like let's say you got, God forbid, somebody got hurt during the pumpkin festival and there's no way to get via traffic, this might be a better way to get to us in a timely manner. It also gives us advanced notification. It also gives us advanced notification that EMS usually calls us, says we're bringing in somebody with an allergic reaction from step letter B, and we'll be ready for them with nursing and the appropriate staff. So I know a lot of people say, I'm fine, I'll go now, or I'll go in the morning. So certain things where I kind of say you should probably go now. So that's fever. Again, we are worried about sepsis, high blood pressure, that could lead to a stroke or an aneurysm, a rash, not just like an allergic rash, but a rash can be something septic or something that you got in contact to that is toxic. And any substance abuse or dependency, because withdrawal from alcohol could be deadly and invoke seizures. So if you're gonna come to the ER or anywhere that you're gonna be seen, if you could bring an updated list of your most recent medications and dose, telephone numbers of your physicians, because we always get in contact with your physicians, being that we might not know you offhand. Any advanced directives that you might have, healthcare contact information, a vial of life. And unfortunately, sometimes we have to wait to be seen, even though we have the shortest wait time in the ER. So some alternatives to emergency care, your PMD is probably your best resource, notwithstanding what we just went over that necessitates emergency care, because they know you and you're integrated into your system. Urgent care, it is a matter of convenience. There is some different cost considerations. I don't know exactly the difference between getting amoxicillin at an urgent care versus an ER, where we have to have triage and we have to be seen by a nurse and a doc or a PA. But again, that falls under that prudent layperson. Okay. And again, like we were saying before, is that most of the time they either refer you or transfer you to the ED if something is more serious. So Stony Brook, which we all work for, is we all have an integrated emergency record where we are hopefully going to get the same EMR that Stony Brook has, but we have links to look up all X-rays and all prior charting on somebody if you kind of came back and forth. All the images are in the cloud, so if I have a broken bone on somebody, the orthopedist at Stony Brook can see the same X-ray that I'm looking at. And as well as obviously Stony Brook has some of the best consultants on the island. So Hammer, urgent care, Hammerhead, emergency care. Just little jokes here and there. So some of the services we don't have, the last one withstanding now is like we don't have OBGYN, we don't have pediatrics, we don't have pediatric mental health, we don't have pediatric surgery. Neurology, there's no neurology, physical physician in-house, but we do have teleneurology and telestroke now. But all these other services are accessible via phone as well as transfer if need be. Phone advice, we rarely give it, just because we don't really want to give information to somebody that we can't see. So sore throat, we can say go see your doctor, but if it's a sore throat because there's something stuck in your throat or you have an abscess, we don't want to give you the wrong information. It's not that we don't want to speak to you, we just think that it'll be better if you're seen in person. So telemedicine, like I was touching on before, this is sort of the new frontier. It's probably going to replace some of the urgent cares because if it's a physical rash or a cough in a population that is not really prone to getting super sick or sepsis, we can prescribe sort of lotions and antibiotics and other medicines via telemedicine. Some of the urgent cares are already doing it, especially during COVID. They did some telemedicine to prescribe medications. And like I said, it started from COVID. And starting to implement that now too. Any questions?
Great, then we will move to our second half of the presentation with Jim Preston from Shelter Island Emergency Services. Let me spotlight and let me quick.
Okay, how's the sound?
That sounds great.
Okay, great. May I begin?
Yes, you may.
Okay. Well, the purpose of my part of the presentation is to familiarize everyone with the Shelter Island Town Emergency Medical Services Program. Okay, it's a line item budget of the town, and the Shelter Island Town Ambulance Foundation funds many of the rolling stock. We have 3 ambulances, all state of the art, covering Shelter Island. We have several different levels of provider. We begin with a driver trainee, we have a driver, we have an EMT basic, and most recently we have an association with Stony Brook Paramedic Program. They're on board 24/7, 365 a year. So that's really quite helpful, and we'll explain the interaction with them shortly. So the anatomy of the call is to explain exactly some of what you just asked. How do we get a hold of the ambulance program, and when should we do that? So everything goes through 911, and it may be initiated by a call to a police from a friend. You may be a friend on the island. You may happen upon someone that has an injury or an incident, or with the new iPhones and electronic life alerts, there may be a direct interaction between the 911 operator. So the dispatch for the Shelter Island Town Ambulance or EMS program is through Southold. It's all served by 911. And when that happens, the dispatchers trained to go through a decision tree on exactly who to call and how to get you help. So the dispatchers then page out to all of the some 20-some members of the Shelter Island Town EMS we're all volunteers except for the paramedics, and we may be at work, on a boat, at home, eating dinner. The pager goes off, and those individuals that are available then proceed to respond to the call. So the communication begins with the 911 dispatch, and then the senior officer, the chief, captain, lieutenant, or the senior person on the call will then coordinate through the mobile radio system that we have as we're approaching the barn and or the scene, exactly who's going to go to the house. So, or the location. So once on the location, we take a situation look and see what kind of scene safety we have, what's going on, and we do an initial assessment, try to get vital signs. We direct the resources, meaning the ambulance or whatever other rescue mechanism we may use. We obtain vital signs. We have access to 12 lead EKGs, which we can then transfer and transmit to medical control in Stony Brook. They may direct us what our destination will be. It may be Stony Brook Eastern Long Island Hospital. It may be Hampton, and it may be the Suffolk County Police helicopter. We'll talk about that in a second. So upon arrival of the crew, the determination is made was the initial provider confident that they can handle the situation, or does it get handed upstream to the paramedic as is appropriate? Okay, so interventions at the scene, we can provide oxygen, we can stabilize injuries, we can treat people for shock, and we can monitor the vital signs to try and get an idea of the severity of the situation. We can help with extrication. Folks may be upstairs in a third floor bedroom, maybe on a boat, maybe in the backyard in an uncomfortable situation. But we have several different kinds of extrication devices. And we now have power lift stretchers so that the safety of the crew is enhanced by their electrohydraulic lift mechanisms. On board the ambulance, we can continue with oxygen. There are certain meds that both the EMT basics can give, and then a full range available through the Stony Brook Medic program. We can give breathing treatments. We'll obtain a complete history and leading up to the issue, and we'll take the vital signs on the communications during the transmit. Obviously, we have to use the ferry for ground transportation. They're available 24/7, and there exists a communication protocol between the chief of the ambulance, the police officer on the scene, dispatch, the head of the ferry, and depending on what time of day, they determine what the availability is going to be for the ferry. We can ask them either to hold at the ferry dock, or we can take the next available boat. We also have, in addition to the 3 ambulances, access to Suffolk County Police helicopter and medics. They're used for cardiovascular accidents, strokes, where we want to get to Stony Brook fast, and it's a last known event within a certain time period. We also use the helicopter for heavy trauma, 2 or more long bones, and certain cardiac issues. They're usually dispatched either from MacArthur Airport or over in West Hampton, based on the time of the year. So when we get to the hospital, we get the patient to that operative space. We present to the nurse or the doctor. We review our documentation and make sure that the hospital has a copy of it. We restock our consumables, check our gear locker, and clean up. And that provides you with a path to get to the hospital, to the emergency room when it's become necessary. So now you're back in the hands of Chris, and we wish you all well. Questions?
All right, great, thank you. Linda, did you have a question? I saw your hand go up.
Yes, I was really interested, Jim, when you said the possible life alert on the iPhone. So
Yes.
while you were talking, I looked, and on my iPhone, it's under settings, under emergency SOS. Which I
Depending
never
on the
did.
iPhone and how you've got it set up, it'll either recognize an urgent fall and call 911,
Yep,
the
and it said
iWatch,
it. It said it,
Apple Watch, the Apple Watches.
yeah, it said what to do, and I never knew that. So
Right.
thank you for that info.
We have experience with a serious fall. Individual went down. The Apple Watch contacted 911. Even though a bystander stopped and rendered help, the 911 system was activated well in advance of the initiation of the bystander call.
Yeah, that I had heard with the phone, with the watch, but I didn't know about this on my phone. I have a 13, and it's under emergency SOS, and it tells you how to activate it. So for me, I like to know before I would need it how to activate it. So
Right.
thank you for that information.
And certainly absent someone to help you with those settings, go to your provider like Verizon and Matitech, and they can help you with it.
Yep. Thank you.
Mixie, did you have any questions for Mr. Preston?
Let's see, just I'll come in here again. Just one second. Yeah, can you hear me?
Yes.
Okay. I'm still not clear about the ferry. I think I heard you correctly. There was some noise outside, and when you were talking about that, I didn't quite get the facts. You said 24/7 at the ER, of course, are always available, but the ferry service only starts like 5:30 in the morning until 11:30 at night. Do they make exceptions for ambulances or people who need to get over?
Oh, of course.
Oh,
Well,
they do.
by our notification to North Ferry or South Ferry, they'll put a separate crew on
Oh, okay.
for the time period when it shuts down at night and starts in the morning. Now, in the past, it was whomsoever just went off shift got called back out, and who was about to go on shift got called back out. But I think there's a separate crew now, and they're compensated for their efforts. Now, in 24 years of being on the ambulance, I don't think I've ever waited more than 10 minutes for those midnight calls. And we're talking 80 knot winds, prohibitive ice and the like.
Okay.
So it's a fantastic relationship that the ambulance has with both fire and the ferries and the police.
Oh,
And one thing I didn't mention, Chris, was that during our time on the ferry, we make an update call to the hospital so that we can alert the people in the emergency room, the emergency department, exactly what's coming over. And they start getting their gear together, meeting us at the door as appropriate.
Yeah.
oh, thank you. That's great to know. Thank you so much. Very reassuring.
That's what it's about to be.
Okay.
Now, the Chris mentioned the mnemonic for the stroke recognition. It's been my personal experience that my peers don't know that the balance or the eyes or the facial droop precede all the serious things that are around with the stroke. And oftentimes we'll find that a friend or a family member, oh, I'm tired, I think I'll take a nap. That's not appropriate. It's time to go. As soon as you miss a step or slur a word, that's not just an unusual happening. That can very well be the beginning to a cardiovascular accident.
Okay.
All right, do we have any other questions from our friends on Zoom? All right, I'm seeing some head shakes. So I think that brings us to the end of our presentation. Thank you so much to Mr. Preston and to Dr. Edelstein.
Thank you, guys.
And a recording of this presentation will be made available in a few days. Thank you, everyone, for coming out, and I hope you have a good Wednesday.
Be well, be safe.